Hi, everybody. Alex Borzak here, Doctor of Nursing Practice student from Widener University. I want to talk about Module 2 of our 4-module set, talking about different aspects of transitions of care programs. In this module, we're going to be talking about best practices for providers. So this is where we're going to focus on areas that providers can concentrate on and look at for those who are working within a transitions of care program, who may be interested in starting transitions of a care program, or might want to add some of these things, these components to their own practice with their patients as well. So we're going to look at a variety of different things here in this presentation. So just to remind you of what the purpose behind a transitions of care program is, and that is really predominantly to optimize the process flow for patients' medical information to follow the patient wherever they go. And we're looking at different points within that continuum of care that are most vulnerable, where information can be lost or fall through the cracks. This is from our last presentation as well, just to give you an idea of the process flow of a patient that would be initiated into a transitions of care program, kind of the general format of how that happens even before the patient is discharged from the hospital, all the way through to day 28 through 30 after they've been discharged from the hospital, that reevaluation as to whether or not they need continued services or different services, or if they can go back to the normal patient panel. This fishbone diagram I put together and put up here in this presentation just to kind of give you an idea of all of the different components that go into making a functional transitions of care program. We talked about before the 7 essentials and the 5 standards of transitions of care programs. This is a little bit more of a broken down chunk into that process, so that we can begin to look at inefficiencies within the process, that we can begin to look at transition points within that process, and different things that you need to consider that make up this entire process of transitions of care, and that you need to account for whenever you're evaluating your program or evaluating your process. So a lot of mini processes go into the larger full process that we saw on the previous slide. So with that in mind, what I've done here in this presentation is boil the focus down to 4 big points, take-home points that you need to consider out of that entire fishbone diagram that I put up on the previous slide. So we're going to look at workflow efficiency, look at goal setting, barrier assessment and referral, and also billing, the big elephant that's sitting in the corner of the room that we unfortunately have to address as well. So workflow efficiency. So there's some different things that you can do to make your visits more efficient, different things that you can do to increase and maximize the time that you have that patient in your office for their appointment. So first of all, you need to look at, is there any chart abstraction done prior to the visit for the patient? And if there is chart abstraction that is done, who is in charge of doing it? Do you have a medical assistant or an LPN or even an RN who does your chart abstraction for you? Or is it going to be one of the front office clerks, and they have like 2 or 3 providers, or your phone triage nurses? Who exactly is doing the chart abstraction? If you don't have chart abstraction, are you able to access all of the records that you need to prior to your patient attending your appointment? If not, then you need to figure out who the point person is who's in charge of that. It may or may not be part of your IT team. It may be somebody else that is in charge of making sure there's documentation there available for you to review. You may need to talk to and consult with your hospital chief medical officer, or you might need to talk to department head of a specific department, whether it be hospital staff, emergency department staff, another private practice or specialist, that kind of thing. So those are some things that you need to consider as part of the workflow efficiency. The next thing that you need to do is consider, what are you using, if any tool, any evidence-based tool, to identify potential of readmission risk and complexity, level of patient complexity. This is going to help us on the other end where we talk about risk stratification and goal setting. Also, scheduling appropriately with your PCP is going to be a big thing. Are they put into the appropriate time slot? Are they given a time that is not going to be longer or shorter than what you need to get through all of the information that you need? Also, are there duplicate appointments? Are you seeing a patient that is on another provider's panel? And then are they coming back in 2 days later and seeing that provider for the same exact thing that they saw you? That's going to be really very important, so that you're not doubling the workload of your staff, but also you're not doubling the work of the patient, especially if they aren't getting any different end result, whether it's any different direction, any different prescriptions, any different labs or diagnostic imaging being ordered at that second visit. Why are they going in to that visit if nothing additional is going to happen? More than likely also, you're not going to be able to bill for that second visit because it's the same type of visit, not only with a different provider. The other thing about scheduling too is to consider the time of when these appointments are plugged into the schedule for the day, and where you have the most adherence to appointment attendance for these types of appointments with your patient panel. You might need to adjust differently, or also, is your schedule locked, or do you have the ability to have an open schedule that gets released later on in the afternoon for the next day appointments, and then they start plugging things in then? Is it on-demand scheduling, or is it pretty solid scheduling? Another thing is, this is something that, especially if you're using like an Epic or even like a Cerner health, electronic health records, may not be as much of an issue. You may be already be able to build some templates in to your charting ahead of time. However, if you have not, that's going to be a big thing to consider, not just for your own sake and sake of mind and sanity during that visit, making sure that you use that as your checklist to make sure that you're hitting all of the points that you need to address to be able to bill at the level that you want to be able to bill. But it's also going to help you later on downstream, so that you can go back and you can pull these records and have an easier time looking at trends, looking at areas that are deficient, and to come up with solutions for them, instead of having to review the entire chart for every single patient in a given time period. Patient attendance gets its own separate category because, yes, we've addressed this before just with the talking about scheduling appropriately with the primary care provider, but patient attendance can get a little bit more complicated and a little bit more complex than what you might think of just, oh, where does it fall within the schedule? The other thing that you have to consider with patient attendance, appointment attendance, are barriers that are prohibiting your patient to be able to make it to the appointment, not just time of day, where it falls within the time of day or appointment length, but also external factors. Is there transportation available? Is the patient able to afford public transportation? Is there childcare that is available? What is the patient's employment status? Those kind of things need to be addressed prior to the appointment to make sure that these barriers can be addressed to at least decrease them to a point where the patient's able to attend the appointment, get them to your office so that you can see them and you can do something for them, versus they no show and then after 3 times they're dismissed from your practice and they're just left to keep going back to the emergency department for all of their needs. The interesting thing is as well that you can consider with patient attendance is where is your office located geographically in relationship to these patients that are routinely missing appointments? Is this something where you need to get together with your clinic staff, with your clinic manager or something, and come up with a satellite location, or do a clinic in the lobby of the housing complex where your patients live or something like that? So is there something more from an outreach standpoint that you can be doing so that these patients are making and attending their appointments? For this last point, identify points of contact and staff in charge of information, not just your IT staff. This goes back to one of the 7 essentials from the NTalk 7 essentials list that we talked about in the last presentation. You need to know who's in charge of what. In order to address any problems, you know who to go to and who to talk to with your evidence and your data, and say, this is a problem. I have the evidence to support that this is a problem, and we need to get this resolved. Let's talk about goal setting for a minute and how this relates to best practices. So these are something that are going to be individual to your patient. And while you might have kind of a setup that is a la carte for your patient, that you can kind of pick and choose what kind of goals you're going to give them. You can have a bunch of standard canned goals that you can, in a protocol list that you can just click on and add into the patient chart with orders and billing and things of that nature. However, it still has to be individual to that patient, what their individual goals are for the care that they want to receive. But then also it has to be appropriate for the time period that you have to complete these. In the context of a transitions of care appointment and track that your patient's you're going to initiate with your patient, these goals must be completed within the first 30 days post-discharge. The literature shows that goals that have been completed by patients within the first 14 days post-discharge are the most successful at making it to day 30 without a readmission. Remember, the whole point of this is to not have your patient readmitted or to go to the emergency department within those first 30 days after discharge. Ultimately, we want to see them prevent remission for longer than 30 days, but in order to get that reimbursement from CMS, from Medicaid, Medicare, you need to have no readmissions that's related to that initial admission within those first 30 days. One evidence-based tool that you might use is something called the patient activation and motivation score, and also motivational interviewing. These can be used in conjunction with your risk stratification and identify patients that are very highly motivated to participate in their care. And then you can also use it to identify patients that are not so motivated, and that you're going to need to spend some extra effort to get them motivated and have them be able to participate in their care at least long enough to not get that 30-day readmission. The other thing that you have to consider when goal setting is, where will your patient be in 30 days? Not every patient that comes to your practice after a discharge is going to stay there 30 days or longer. And so if your patient tells you that I'm planning on moving to Florida in a week, and this is 2 days after they've been discharged from the hospital that you're seeing them, then you need to adjust the goals to whether you do it within that week, or you work on within that week getting them set up with their new primary care provider wherever they're moving to, so that they can continue care without that big gap, and putting them up for a readmission or a visit to the ER in a different location, maybe even in the same ER that they were initially. So that's something that you can look at and consider as your goal setting and looking at your patient as well. Also, if you know that your patient is going to be moving or they want to see a different provider within that 30-day time frame, that's also going to help dictate what type of resources and interventions you plan for your patient in the meantime while they're still under your care and they're still on your patient panel. Assessment of barriers, we touched on this just a little bit, but this is also going to be combined with your goal setting. So you're going to do kind of two different barrier assessments. Your first barrier assessment during that initial follow-up phone call is just to see if there are any barriers present and what those barriers are to getting them to their appointment at the clinic. Once you have them in the clinic, now you can do a much deeper barrier assessment to see if there's going to be anything that's prohibiting them from receiving care and management of their care on an outpatient basis for an indeterminate amount of time. So there's two different steps to this. So this barrier assessment is really important because if so you got them to the initial appointment, if they need follow-up appointments or they need to go to get specialists, even though you got them there for that first appointment, if they can't make their specialist appointments and they end up going back to the emergency room and getting admitted to the hospital again in a week and a half, that doesn't do you much good if you're trying to prevent a minimum 30-day readmission for your patient. There are additional inventories that you can utilize to assess for these barrier assessments. They can be completed while the patient's waiting for their appointment in the waiting room. They can be done at the end of the appointment. They can be done with the provider and case management in the appointment as well. You can get a really good idea during that initial phone call as well and start kind of pre-planning some potential interventions for potential barriers that might have come up during that initial phone call. The other thing you have to consider, if you're going to use written inventories and you're going to have your patient read them and record their responses that way, you need to consider the reading level and the literacy level of your patient. If they don't have a very high reading level or literacy level, then you need to choose an inventory that's going to be appropriate for their level of comprehension. You might have to read each question to them individually and mark down their response that they give you. And then along with barrier assessment, okay, great. So you assessed for barriers, you identified some barriers. Who is the person on your care management or social work team that is responsible for addressing these outside of the appointment? If you don't know who that is and you're just putting them in a chart and you're not doing anything with them, what's the point? Why are you doing this? So those are some things to consider. And then the last point that we need to talk about is that ugly stepchild or the elephant in the corner of the room, and that is billing. Nobody likes to talk about money in medicine. However, in order for you to continue to have a practice and you need to address the financial ends of things as well. So there are a few things that you need to consider with transitions of care. So TCM codes are billed 30 days post-discharge. So you have to provide the services first without getting any immediate reimbursement for costs. And this is not necessarily very appealing to practice administrators or to health systems because of that delay of care. They're taking a big gamble on these patients not having a readmission within those first 30 days. And if they do, then they're out all of that money. They can't go back and retroactively bill for a follow-up visit, that kind of thing. So once you start down this TCM pathway, you're in this TCM pathway until they complete it, until they graduate from the program. So, and you can't combine this with regular office visit charges. So TCM is a whole separate billing. However, though, because of that risk, that's where risk stratification tools and techniques come in to identify those patients that are going to benefit the most out of these services and are going to have a high potential to be able to process and utilize those interventions and keep them out of the hospital, at least for those 30 days post-discharge. You can bill additional services as part of the TCM billing bundle. So there's a whole bunch of different codes out there that you can use. So CMS does recognize that this is a very big undertaking and big time commitment on the part of the provider and the office staff. So there are things that you can bill for under the hood of TCM that you can bundle with the regular TCM visit charges. They include remote patient monitoring. If you have a patient on like a continuous glucose monitor for 16 consecutive days, you're able to bill for that. CCM services, if applicable, you can bill for those. Patient education, there's 2 different levels for moderate and complexities. You can also have billing that are directly billed by your APP or your clinical pharmacist. And then there are also some services that you can bill that are instant to either your primary care provider, whether they be a APP or an attending, or there are charges that you can also bill instant to the physician in the office as well. So there is still some flexibility with billing that you can add on to get some reimbursement for these patients. However, again, none of this can be billed for until after that 30 days that you've been able to show that your patient hasn't had a readmission within that time period. The other big bonus, though, about utilizing a TCM model is that the ACMA came out within their 5 standards is a list of metrics that can be addressed and that you are also working towards and reducing when you have patients in the transitions of care. You're utilizing a transition of care model or program for these particular patients, things like glucose control, blood pressure control. Furthermore, you are also addressing different areas of the Healthy People 2030 categories as well by preventative services provided through this transitions of care model. So there are other benefits to utilizing this model in your patient care delivery for your patients that have been discharged or are your high utilizers for hospital services. So with that, that is going to wrap up best practices. Again, that's just a brief, broad overview of some of the things that you can incorporate into your own practice related to transitions of care. So if you would like to, I'd ask you go ahead, pick up that smartphone, open up your camera app once again, hold it up to the QR code, click on that link, and complete that survey. Thank you very much for your time and appreciate your attention.